Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast. In today's episode, I want to briefly talk to you about my, I would say, limited understanding of coding. I am not a coder by trade. I know a lot of friends and colleagues in the hand and foot world that are extremely more knowledgeable in coding because they have to deal with the complicated aspect of multiple codes and multiple procedures for every case. In our world, basically total knee code, total hip code, it's pretty simple. Revision code, one component, both components. But I think in the office, there's more of a disconnect. And hopefully, you have had exposure to coding in med school or in residency or on rotations. I had pretty much none. I remember going into practice and it was like, okay, here's your bill, fill it out. I had no idea. So, I asked a lot of questions, and I'm sure I probably did it wrong for a while. And, I'm still to this day, learning. Why? Because coding is evolving. The insurance companies constantly change the rules, and it makes things difficult. And then you have competing interests, right? You have the doctor just trying to do their job, which I think in a lot of ways, if you work in a setting where you just get paid a salary, it's kind of nice because you see the patient and you do what you have to and what's important, and you dictate it and you move on to the next patient. In a RVU-based or productivity-based model, you got to see the patient. You have to do your job and care for the patient, but you have to dictate it appropriately and code it appropriately. And sometimes it's a matter of, one little line. And then you have these EMR companies coming in and selling a bill of goods to hospitals and institutions like, oh yeah, we have a great way that you can upload all this different stuff and, it adds all this information so you can upcode. And then you have the insurance companies doing everything in their power to go back and figuring out, okay, well, how do I, combat that and downcode? But it's a weird battle, right? Our business is like the only business where I think you could ever, have companies, you hear about insurance companies where, they go back retroactively and, review cases from 3, 4, 5 years ago and realize maybe that you didn't document appropriately. So, they feel they overpaid you. So although you submitted a bill now 4 years down the road, they're going to withhold money that they owe you because they feel that they overpaid you years ago. I mean, it never would happen in any actual real business model. And then there's a lot of things that we do for free. And I think physicians are dumb because of that reason from a business standpoint, right? We always want to care for the patients. The global is the key glaring thing, right? If you have a patient who has an H&P and a surgery and 1 or 2 post-op visits, 90-day global, all that's included in the fee, so be it. But, we're taking care of many more complicated patients that, the H&P is not straightforward. There's a huge discussion. There's a huge component. There's a lot more testing in labs, and you have to assimilate all of this information. And then those more complicated patients require a lot more time on your hands making phone calls that essentially are free and, having the patient come back to the office for wound checks and rechecks, and all of those visits start to add up. So, I believe that, we're definitely not getting paid for the work that we do, and it's a hard thing to talk about in public because, outside of medicine, everybody, has the understanding that doctors make a good living, and we do. But when you look at all the data and you see inflation and the amount of work required, and many more studies are coming out showing, we're not getting paid well enough for what we do and the risk that we take. So, if we were making an actual good amount for, say, a total knee or total hip, I'd say that would be for the procedure, and that those visits shouldn't necessarily be part of that 90-day global. Or you should have some extra billable event that may not be the standard established, but some different sort of code that you could allow that would say, hey, you get 2 post-op visits, but If you have more than two, you can bill for those. What's the downside? People abuse the system. So let's say you had a global that included 2 visits. You're going to get doctors seeing their patients every week just so they could upcharge. So we've created a lot of the problems ourselves. But that kind of gets off on a crazy tangent. The gist of this I wanted to talk to you about is office visits and the idea that I see a lot of people have some just issues understanding like what we're actually talking about. So realistically, there's really kind of 3 office visits. And in reality now, just 2. So you have established visits, you have new visits, and consultations. And consultations basically are disappearing quickly, if not completely. And many insurers won't pay for them anymore. So even if you do try billing a consult, they're going to down code it, or your biller coders are going to down code it to a new. There's probably some specialties in the future, if those codes exist, that you may still be able to bill, but in our world, I have very few, if any, insurance companies that still will pay for a consult. And a consult has to include a request from a doctor. So this is a specific doctor sending a patient to you for a specific problem. And in the consult, you need to dictate that. This patient was referred by Dr. So-and-so for this particular reason. And then you have to evaluate and, render this care and say, I evaluated the patient, this is all the normal, HPI, physical, all that stuff has to be in there. But, basically this is the diagnosis and this would be the plan. And then you have to report this person back to their doctor. So you say, okay, I made this decision and this is the plan. And then I'm going to send you back to the doctor and they're going to execute all those things. As soon as you accept care of the patient, even if someone sends a patient to you for knee pain, but you assume care and you're going to do a total knee, it's not a consult anymore. But many insurance companies won't pay for that. So let's talk about the difference between new and established. So new visits, these are the 9920 1, 2, 3, 4, 5. So a new visit is a patient that is new to you, and they cannot have been seen for 3 years by the same group and the same specialty. Now, this gets a little confusing based on where you're at, so you have to understand the rules. Like in our setting, hand is its own subspecialty. So even though they're orthopedists, if they've been seen by the hand guys, I can bill it as a new visit. But if they've been seen by the sports or foot and ankle or spine or shoulder, that's part of the same group under our billing umbrella. So that's not a new, that would be an established visit. So you have to kind of understand. And it's weird because technically if you did a knee replacement on someone 5 years ago, from my understanding, and they haven't been seen in 5 years, so it's, new to, the group, new to the visit in 3 years, technically still a new visit. But if you've seen them 2 years and 360 days ago, it's still an established because it's been within 3 years. So an established visit is anybody that's been seen within 3 years, even if they haven't been seen by you, but they've been seen by someone in your group, in your specialty. So this is where it gets a little confusing. And these are the 9921 codes, 1 through 5. So the important thing, and you would love it if your biller coders would do this ahead of time. Our old, if you go back 2 systems where we actually had a bill, on the actual bill, it was very nice. Up top, it would say last seen, and it actually had the date. Now we've gone through all scripts and now with Epic, and it's more confusing than ever. And it would be really nice if it just kind of popped up that, was seen by Dr. So-and-so on this date. Patient is, established for you or new for you because they haven't been seen within 3 years. That would make my life a whole lot simpler, but maybe in there, maybe the institution didn't buy it, but it doesn't pop up and no one's ever pointed it out to me in an easy to understand format. But that's the important thing for you to understand. 3 years, that's the big cutoff to the day, same group, same specialty. So the next important thing to understand is the difference in those levels. And we talk about levels 2, 3, 4, 5. For the most part, most people in our world bill level 3. Most visits are level 3. And that's going to cover sort of your evaluation. You can do these based on time. So I do know a lot of people that when we see patients, a lot of times it's complicated, especially if you're talking about surgery or a complex issue. And if it's a focused exam on, say, the knee, there may not be a whole lot of other stuff that you're adding in there as far as the HPI and the social history and the family history, surgical history, and the rest of the exam. Although with the EMRs, they'd love to sell it to you that, oh yeah, we auto-populate all that stuff. And a lot of that stuff can be in there, especially if the patient has input it ahead of time themselves. They've basically been questioned, so the data is there. But you may be doing a lot of stuff based on time. And I've heard this two ways. So, I've seen it discussed as an average time. So the way I kind of always understood that, if I wasn't actually calculated it on my watch, was approximately X number of minutes has been spent with the patient, where the biller coders nope, they want, not approximate. They want actual number, that or above, so it doesn't get kicked back. So when we're talking about a level 3, what we're actually talking about, if it's an established patient, is 15 minutes of time. Whereas if it's a new patient, it's 30 minutes. So what you may see in some notes, if there's not a huge physical exam and a lot of it has been discussions, is you may say 15 minutes of time was spent with the patient, more than 50% of that time was spent on patient counseling. Or if it's a new visit, 30 minutes was spent with a patient, more than 50% of the time was spent on patient counseling. It's great if you have a stopwatch or you kind of know exactly. I know a lot of the hospitalists, if they're walking into rooms, you open up the computer and start your note. It's a really easy way to track when the encounter started. I still try to look my patients in the eye and talk to them and touch them and examine them, as opposed to touching a keypad and having my back to them. So I try not to open up the electronic medical record so I don't have that note started in a timestamp. So I'm trying to watch my time when I'm entering and exiting the room. Now, if it's a level 4 visit, the times are a little different. So for an established visit, level 4, your time would be 25 minutes. And a new visit would be 45 minutes. So you're very rarely going to see a doctor in orthopedics for a knee patient in the room for 45 minutes. And a level 5, 60 minutes. Now, do I hit those level 4s and 5s for new patients? Yes, rarely. When is that? Typically, this is a second, third opinion that is coming into my office with usually prior surgery and a complex history. They have x-rays, they have op notes, they have multiple scars, they have, usually some issue about outcome and infection. And this is a long discussion. This is a visit that takes a lot of time. And I'll put in there all those things of, the fact that it's complicated, and very, very detailed history, very, very detailed exam, and I'll go through all those records, any x-ray op note, although it's scanned in, I give a little brief summary of, op note on this date, pertinent findings, maybe implant sizes, x-rays, all the x-rays, pertinent findings, but I'll put in there, those descriptors of the time because of the complexity. But for the most part, most visits are level 3, newer established, and occasionally level 4 for the complicated patient. So it's important to know exactly what that requires, though, because a lot of people will bill level 4, and although you may have done the work, if you did not document it, it did not occur. So there's some really neat cheat sheets that you can get. Sometimes the biller coders will have, and they'll give you a little dry erase thing. It kind of reminds you of how many parts of the HPI do you need, how many things of the physical exam, how many things of the review of systems. Couple interesting little things that I found over the years that are somewhat helpful. But if you're doing, say, an established level 4, for the most part, I'm billing based on time. But in your history, there's this sort of reminder of the 4-2-1. So you need 4 elements of the HPI in the history. 2 organ systems. And 1 extra element of the past medical or past family or social history. And then in the exam, you need 4 of 4. So it's 4 items in 4 different organ systems. So, it's a little bit harder if you're talking about orthopedics because you're talking about the musculoskeletal system. Did you listen to their heart? Did you bring a stethoscope? Did you listen to their lungs? Did you do a neurologic exam, which, we can sort of incorporate, that neuro exam and the orthopedic, but you may not be hitting 4 different organ systems. The other issue is 12 bullet points. So even a negative, is considered a bullet point. So if you go through 12 different systems, it's going to be hard in an orthopedic environment. So you'll see a lot of interns or medical students come through and may be that thorough, but when you're busy and you're seeing multiple patients, you may not go through every system that way. And I do not recommend, and I think it's dangerous to, use this sort of auto-population system if you're not going to go back and look at it, because, if there's people that will use like the negative for everything and they have it all in there, and then they're physically going back and adding when those things are positive. But, if you don't go back and change those things, you're instituting this, issue of, medical things in the note that aren't necessarily correct. So you have to be very cognizant of how you use the current EMR systems. And if you're going to try to use all these little negative drop-ins, just be aware that if you default them to a negative and they're positive, you may have to make sure that you go back and change it. So the gist of all of this is, if you're in the office, for the most part, you're not going to be billing a consult. You're going to be billing, a new or established. The big cutoff becomes 3 years, same group, same specialty. If they have been, it's established, even if you haven't seen them. If they haven't, it's new. A level 3, established 15 minutes, new 30 minutes. Established 4, 25 minutes, new 45 minutes, and then just have your pertinent things. Because, as an orthopedist, we're fixating on the joint. And when I talk to people, though, I'm a doctor first. So, I may not go into super detail like their specialist would or their primary, but it's all part of the same person. So I will, in my assessment and plan, if someone's overweight, I will document that as, right knee pain, osteoarthritis, but number 2 becomes obesity, BMI of 37. And in the plan, I'm discussing the fact that I talked to them about their weight and the importance of weight management and gave them my handouts on weight management. And if they're diabetic, I'm putting that in there. Number 3, diabetes, whether or not insulin controlled or non-controlled diabetes, uncontrolled diabetes, because again, in my plan, I'm discussing the importance as a doctor. Hey, number 1 reason for non-traumatic amputation in the U.S., uncontrolled diabetes. Number 1 reason for blindness in the United States, diabetes. Talk to them about control of their sugars. If they've done well, I give them the 2 thumbs up and congratulate them. But I put that in there, and it takes, one little, line to discuss it. But I noticed it, I talked to them about it, and I mentioned it, I put that in the note. If they're a smoker, it's in there. If they're cardiac disease, I put it in there for 2 main reasons. 1, are they on a beta blocker? 2, are they on a blood thinner? And again, little one-liner, but I noticed it, I mentioned it, I talked about it, I put it in there. And, why is all of that important? Well, I don't remember every single patient. I would say I used to when I started. I remembered everything because I didn't have a whole lot of patients and I wasn't that busy. Now after 15 years, the number of patients grows exponentially and you're seeing a lot more people, and some you may not see for years. And some, you may see very frequently after you meet them for their consult and operate on them. And all of those things are fresh in your brain. But if I haven't seen somebody in, say, 9 months, and they're overweight and now they've lost weight, I want to congratulate them. And if they were overweight and gaining weight, I want to talk to them about it some more, or maybe refer them on to a specialist. If they're diabetic, I want to know, because I give out the same spiel for every cortisone injection, but when I see the diabetes, I reinforce the fact their sugars may go up. If somebody is on a blood thinner, it reminds me to ask, are you still on the blood thinner? And if so, I'm not going to be recommending Motrin, Advil, and Aleve if they have some swelling and pain from their arthritis. And if they have a procedure, it lets me know that I have to be aware of the bleeding issue, even from a needle stick in the office, or if we're going to have surgery, I have to get cardiac involvement for clearance. So it is in there for particular reasons. But from the insurance company, the billing standpoint, it proves that you did it, you talked about it, you mentioned it, and it's in your note. But I find that those things are really important when you're doing billing, because it makes you a better provider, because you don't forget what those patients' main medical issues are, even though you're just seeing them back for their knee arthritis or their hip arthritis. You remember also they've been struggling with their weight, they're diabetic, and they're on some chemical agent for blood thinning because they have atrial fibrillation. And these are all pieces of the puzzle that allow you to render better care. So a whole bunch of information on coding. And again, just a brief overview. I am not an expert. Again, my hand and foot and ankle guys are kind of jealous because, my surgeries are essentially, half a dozen codes. And, in the office, essentially we got 4 codes, new established, level 3, level 4. But when I'm doing those things, again, I'm also adding in the codes for obesity, diabetes, smoking, heart disease, in addition to my arthritis, primary, secondary, post-traumatic, et cetera, what have you. So, knowing those codes and having a cheat sheet, saving them as your favorites in your EMR, this makes your life a whole lot simple. And although it may take a lot of time in the beginning, it's going to pay itself off in the end because it makes you more efficient towards the end of the day. Most importantly, though, I would say is take a coding course. Karen Zupko and Associates, they do great coding courses. I have a lot of friends and colleagues that like the Academy AAOS Codex because it's nice because I haven't played with it in years, but it used to be able to, you can cross-reference back and forth. So you can go from CPT code to your ICD code or vice versa. So if you have a diagnosis and you're looking for a code, it allows you to go back and forth, which is really, really a nice option, especially in those procedures where you're doing multiple procedures, like in the hand and the foot. Again, for the knee, pretty simple, total knee replacement. But definitely food for thought and something to keep your eyes open to in your 4th and 5th year of practice and in fellowship, because all of a sudden the thing changes and one day you're the attending and they go, okay, Bill. And if you haven't had any experience, you're going to be learning on the go. So it's a lot easier to ask questions ahead of time and start to have an understanding before you start your first day of practice. So thanks again for listening. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.